Welcome back to our channel where we discuss various medical conditions and diseases. Today, we have a special topic, angina pectoris. This condition, often described as chest pain or discomfort, can be a serious warning sign of an underlying heart issue. In this video, we'll explore what causes angina pectoris, how it affects the body, and the latest treatments available and nursing management about it. So, if you or someone you know is dealing with this condition, stay tuned as we delve into the crucial information that could help manage or even prevent this type of chest pain. Don't forget to like, share, and subscribe for more insightful medical content. Let's start with the basics. What exactly is angina pectoris?
Angina pectoris is a clinical syndrome usually categorized by episodes or paroxysms of pain or pressure in the anterior chest. These episodes occur when there is insufficient coronary blood flow, resulting in a decreased oxygen supply when there is increased myocardial demand for oxygen in response to physical exertion or emotional stress. In other words, the need for oxygen exceeds the supply.
Could you explain the pathophysiology of angina pectoris?
Certainly. Angina pectoris is usually caused by atherosclerotic disease and most often is associated with a significant obstruction of at least one major coronary artery. Normally, the myocardium extracts a large amount of oxygen from the coronary circulation to meet its continuous demands. When demand increases, flow through the coronary arteries needs to be increased. When there is a blockage in a coronary artery, flow cannot be increased and ischemia results. Several factors are associated with typical anginal pain, such as physical exertion, exposure to cold, eating a heavy meal, and stress or any emotion-provoking situation. Unstable angina is not closely associated with these listed factors. It may occur at rest and also it is categorized in ACS.
That's fascinating. What about the clinical manifestations of angina pectoris?
The manifestations of angina pectoris can vary in severity, ranging from mild indigestion to a choking or heavy sensation in the upper chest. The pain may be accompanied by severe apprehension and feeling of impending death. It is often felt deep in the chest behind the sternum in the retroesternal area. Typically, the pain or discomfort is poorly localized and may radiate to the neck, jaw, shoulders, and inner aspects of the upper arms, usually the left arm. The patient often feels tightness or a heavy choking or strangling sensation that has a whiz-like insistent quality. The patient with diabetes may not have severe pain with angina because autonomic neuropathy can blunt nociceptor transmission, dulling the perception of pain. Other symptoms that may accompany the pain include weakness or numbness in the arms, wrists, and hands, as well as shortness of breath, pallor, diaphoresis, dizziness or lightheadedness, and nausea and vomiting. An important characteristic of angina is that it subsides with rest or administration of nitroglycerin. In many patients, anginal symptoms follow a stable, predictable pattern. However, unstable angina is characterized by attacks that increase in frequency and severity and are not relieved by rest and administration of nitroglycerin. Patients with unstable angina require medical intervention.
Are there any particular considerations for geriatric patients with angina pectoris?
Yes, there are. The older adult with angina may not exhibit a typical pain profile because of the diminished pain transmission that can occur with aging. Often the presenting symptom in older adult is dyspnea. Sometimes there are no symptoms like silent CAD, making recognition and diagnosis a clinical challenge. Older patients should be encouraged to recognize their chest pain-like symptom, for example, weakness, as an indication that they should rest or take prescribed medications. Pharmacologic stress testing and cardiac catheterization may be used to diagnose CAD in older patients. Medications used to manage angina are given cautiously in older patients because they are associated with an increased risk of adverse reactions. Invasive procedures, for example PCI, that were once considered too risky in older adults are now being performed successfully, and many older adults benefits from symptoms relief and longer survival.
What about the diagnostic process for angina pectoris?
The diagnosis of angina begins with the patient's history to understand their symptoms. In addition to a detailed history, a 12-lead ECG can help identify changes indicative of ischemia, such as ST segment elevation or T-wave inversion, or the development of an abnormal Q wave. Laboratory studies, including cardiac biomarker testing like troponin levels, are performed to rule out acute coronary syndrome. Additionally, stress tests such as exercise stress testing or pharmacological stress testing with nuclear imaging or echocardiography can be used to assess the functional capacity and detect areas of myocardial ischemia. Echocardiograms, nuclear scans, and invasive procedures like cardiac catheterization may also be utilized to visualize and confirm the presence of coronary artery disease and assess its severity.
Once the diagnosis is confirmed, how is angina pectoris managed?
The medical management of angina pectoris aims to decrease the oxygen demand of the myocardium and increase oxygen supply to alleviate symptoms and prevent complications. This is achieved through pharmacologic therapy, control of risk factors, and reperfusion procedures, and procedures like PCI, PTCA, or CABG if necessary. For pharmacologic therapy, nitrates such as nitroglycerin are commonly used to relieve chest pain during angina episodes. Beta-adrenergic blocking agents such as metoprolol or atenolol are prescribed to reduce heart rate and myocardial contractility to decrease the oxygen demand. Antiplatelet medications such as aspirin, clopidogrel, prasugrel, ticagrelor, and anticoagulants such as heparin, enoxaparin, deltaparin are often prescribed to prevent thrombus formation and reduce the risk of myocardial infarction. Calcium channel blockers reduce heart rate and myocardial contraction, decreasing heart workload. And they also dilate coronary arterioles, increasing oxygen supply and reducing oxygen demand. Commonly used calcium channel blockers are amlodipine and diltiazem, which are prescribed for angina and hypertension. Side effects include hypotension, atrioventricular block, bradycardia, and constipation. Adenosine diphosphate receptor antagonists, P2Y12, block platelet activation and take a few days to achieve antiplatelet effects. Clopidogrel is commonly prescribed with aspirin for high-risk MI patients, and prasugrel and ticagrelor are alternative options for coronary events. And side effects for these drugs include bleeding. Glycoprotein 2B3A agents like abciximab and epitiptide are given intravenously for unstable angina and as adjunct therapy for PCI. They prevent platelet aggregation by blocking glycoprotein 2B3A receptors, reducing clot formation. And bleeding is the major side effects of these agents. Oxygen therapy is used to increase myocardial oxygen delivery and relieve chest pain. Oxygen saturation is monitored using pulse oximetry with normal levels above 95% on room air. The other advice for these patients is lifestyle modifications such as smoking cessation, healthy diet, weight management, regular physical activity, and stress reduction play a crucial role in managing angina pectoris. Cardiac rehabilitation programs, which include supervised exercise training, education, and counseling are recommended to improve heart health and overall well-being.
Can you share some effective measures to enhance a patient's ability to perform self-care after discharge?
Certainly. After discharge, it's crucial to identify patient priorities. Adequate education about life with preservation is essential. This includes understanding self-care methods and their importance.
Excellent. Now, let's talk about heart health. How can we facilitate patient participation in cardiac rehabilitation programs?
Great question. Customizing rehabilitation programs to meet specific patient needs significantly increases the chance of successful treatment. By involving patients in program development, we empower them to actively participate in their recovery.
Transitioning to continuous and transitional care, what factors influence the type of care a patient receives?
Well, location plays a role. Patients' access to family assistance and community-based resource matters. Home care is essential. Nurses help patients plan and maintain follow-up care, ensuring adherence to prescribed diets and medications. For patients receiving oxygen at home, proper administration and safety are critical.
Understood. Now let's address secondary heart failure due to myocardial infarction. What care guidelines should we expect for these patients?
When symptoms of secondary heart failure arise, immediate attention is crucial. Patients with heart failure should follow a comprehensive care plan, including regular assessments, pain relief strategies, and adherence to cardiac rehabilitation. The goal is to minimize complications and maintain overall well-being.
Thank you for sharing these insights. Lastly, what outcomes can patients expect from this approach?
Well, patients can anticipate pain relief, stabilization of cardiac and respiratory status, adequate tissue preparation, reduced anxiety, adherence to self-care plans, absence of complications, and successful participation in cardiac rehabilitation.
Thank you, Hassan, for shedding light on angina pectoris and its management. This has been an informative and insightful discussion. We greatly appreciate your expertise. And thank you to our viewers for tuning in. Remember to subscribe to our channel for more healthcare discussions. Until next time, stay healthy, stay informed.